Hello, my name is Tom Buchholz, and I have the pleasure today to moderate today's tumor board discussion. And first off, I'd like to introduce a truly outstanding multidisciplinary panel who's going to be talking over our cases today. First, I'd like to introduce Dr. Frank Vicini. Frank's representing radiation oncology. Dr. Vicini, can you tell us a little bit about yourself?
Sure. I'm based in Michigan. I'm fellowship trained in breast cancer radiation therapy, been involved in clinical trials through the National Cancer Institute and even internationally. So my focus is on early stage breast cancer and reducing long-term morbidities.
Thank you, Dr. Vicini. For our surgeon today, we have another national thought leader in breast cancer, Dr. Terry Mamounis. Dr. Mamounis, would you care to introduce yourself, please?
Yes, thanks, Tom. Terry Mamounis, I'm a breast surgical oncologist based in Orlando, Florida. Direct the comprehensive breast program at the Orlando Health UF Health Cancer Center. I also work with the NSABP and now NRG Oncology as the chair of the breast cancer committee, and have been in the business of designing and conducting clinical trials for almost 30 years.
Thank you very much, Terry. And representing medical oncology, we have Dr. Ruth O'Regan. Ruth, would you mind introducing yourself, please?
Yeah, hi, I'm Ruth O'Regan. I'm a breast medical oncologist from the University of Wisconsin, also Deputy Cancer Center Director of the Carbone Cancer Center. And my area of interest really is in clinical trials in resistant breast cancers, including triple negative breast cancer. So I'm very happy to be here and look forward to discussing these cases.
Thank you, Ruth. And finally, the fourth panel member representing diagnostic imaging and radiology is Rennie Butler. Dr. Butler, would you introduce yourself, please?
Hi, and thank you. I'm delighted to be here as well. I am a diagnostic radiologist with a specialty in breast imaging at the Yale New Haven Hospital and on the medical faculty of Yale School of Medicine. I'm also participating in clinical trials. My main area of interest is digital breast tomosynthesis, which is a relatively new technology that has made mammography a better test, as well as breast MRI. And I look forward to discussing these cases with the panelists and learning from each other.
Thank you, Dr. Butler. Case number 4 is going to be presented by Dr. Vicini. It's go ahead, Dr. Vicini.
Sure. This is, again, a 64-year-old postmenopausal female on routine screening mammography, had a density in the breast. Clinically non-palpable axilla was negative. I think you have a mammogram for it as well.
Yes, maybe we'll have Dr. Butler comment on this mammogram.
Sure. This is a similar case as maybe 2 cases ago in terms of the imaging alone, but the mammogram here again shows a non-dense background, and so it's very easy to appreciate this mass. And we've talked about invasive lobular carcinoma being one of the histologies that is more often multicentric and bilateral and often underestimated in its extent by the mammogram and ultrasound. But in this case, I think it's less likely that to be the case because we see the background of the breast so well. And the sensitivity in this type of mammogram is high. Of course, histologically, the tumor may be larger than appreciated, but we worry a little bit less in these cases than we do in the patients with dense breasts, where the findings are very mammographically subtle.
Do you ever see lymph nodes in the MLO view of the mammogram? And do you carefully look and see if the lymph nodes look normal or abnormal?
Absolutely. We often do see level 1 lymph nodes in particular on the MLO view. And in the axilla, we don't evaluate lymph nodes on the same basis as we do in other parts of the body. So for example, we don't evaluate them specifically on the basis of size, but rather on the basis of morphology. Lymph nodes can be quite large in the axilla and still be normal when they're fatty replaced. But what we look for to assess whether or not they may be metastatic is whether or not they have retained their normal kidney bean shape, or the reniform shape, and their fatty hilum. And when they start to lose that fatty hilum because they've been infiltrated by metastatic tumor cells, we see that they become more round and more dense, and we don't see a central lucency that would be typical of a normal lymph node.
Thank you. Dr. Piccini, can you tell us how she proceeded with her treatment?
Sure. She underwent a core biopsy showing invasive ductal carcinoma. It had some lobular features, ER/PR positive, HER2 negative, low grade, and she desired breast conservation.
Why don't we go ahead and just talk about the finding then of her lumpectomy specimen?
Sure. So the lumpectomy showed a 1.9 centimeter invasive lobular carcinoma primarily, with 2 millimeter negative margins. Of interest was the fact that she had one of 3 sentinel lymph nodes involved by a 3 millimeter metastasis with no extracapsular extension.
So let's move to Dr. Mamounis then. Terry, it looked like she indeed was a very straightforward breast conservative case who desired that. We commented earlier about the performance of sentinel lymph node surgery and how effective it was when all the sentinel lymph nodes are negative. Here we have a sentinel lymph node that is positive. How do you approach cases like this then?
So for patients who present with clinically negative axilla, as this patient, and undergo sentinel lymph node biopsy and found to have a low number of positive sentinel nodes, randomized clinical trial results have challenged whether these patients need a completion axillary dissection. We have several clinical trials, most importantly the ACOSOC Z11 trial, also a European trial, a BCSG trial for patients with micrometastases in the sentinel node, where patients that undergo breast conservation and they will also receive breast radiotherapy. The ACOSOC Z11 trial showed that the performance of completion axillary dissection for 1 or 2 positive sentinel lymph nodes did not improve on long-term outcomes in terms of disease-free or overall survival. So based on those studies, essentially for patients that undergo lumpectomy and are to receive breast radiation, we typically do not go back and perform a completion axillary dissection unless there are some features that necessitate that, such as extracapsular extension or large macrometastases or very adverse histology of the tumor. So this is a fairly representative patient, I believe, for the Z11 trial. So with 1 out of 3 sentinel nodes positive, and that's important as well, how many nodes are removed, how many are positive, with only a 3 millimeter metastasis and no extracapsular extension, I think just performing the sentinel lymph node biopsy alone and rely on the breast radiotherapy and the systemic therapy to control the disease is very appropriate. So I would not recommend completion axillary dissection for this patient.
Are you really happy that she wasn't treated with a mastectomy? Are you happy that she was treated with breast conservation?
Yes, and of course, as I mentioned, the data are mainly now of 4 patients that have breast conserving surgery and postoperative radiotherapy. We do have some data for mastectomy patients, although they're limited, from prospective trials. And now that we have actually a prospective clinical trial that's looking at that question for patients with 1 to 2 or 1 to 3 sentinel lymph nodes and a low Oncotype score to see what the effect of radiotherapy for those patients would be in terms versus completion axillary dissection. Yeah, obviously you prefer if it's breast conservation because of the radiation, but on occasional patients with mastectomy, we have, as I mentioned earlier, a multidisciplinary tumor board discussion and ask the radiation oncologist if you need additional nodes to make a decision regarding radiotherapy, then obviously we may go back and take more. But if radiotherapy sort of is decided anyways because of the presence of 1 positive node, then we don't believe that completion axillary dissection is still necessary, particularly if the radiation oncologists are willing to radiate the axilla per se, which we have seen from another randomized trial, the Amaros trial, that local control is as good with radiation of the axilla as with completion axillary dissection. But lymphedema rates and other comorbidities other morbidities are actually reduced with radiation compared to additional surgery.
Thank you, Terry. Dr. Vicini, back to this case that was treated with breast conservative treatment now, and what are your thoughts with respect to radiation techniques and fields and dosages, et cetera?
Right. Well, the Z11 study that established what Terry was talking about included whole breast irradiation. So there was speculation that part of the control in the axilla may have been due to the upper border of the radiation field. And so the question to us as a radiation oncologist is, should we just go with standard tangential fields, which cover a variable amount of the lower axilla, or should we extend our tangents, what are called high tangential fields, where 2/3 to 3/4 of the levels 1 and 2 of the axilla are covered? Or do we feel that this patient requires comprehensive regional nodal radiation therapy, meaning treating the entire axilla as well as the supraclavicular fossa? Some of the determinations to that depend upon, as Terry was mentioning, how many lymph nodes are involved, the size of the lymph nodes, extracapsular extension, and sometimes, the grade of the tumor and some of its biology. But for a typical patient like this, where there's only a 3 millimeter metastasis, I think standard tangential fields with standard doses of radiation therapy would be more than adequate.
Would you particularly contour the lymph nodes that are in that tangent field just to see what dose they get, or do you completely ignore the lymph nodes?
No, we take a look at that, and pretty much every patient, we look where the nodes that were removed, how they fit into our tangential fields. But again, in this particular patient, because of the low amount of disease in the axilla, I would be less concerned. However, if she had a larger metastasis and extracapsular extension, and we were not going to do more surgery to the axilla, we would definitely contour them and take that into consideration and base the dose upon their location and how the tangential fields covered them.
And I'm going to ask you the same question I asked Dr. Mamunis. Are you glad she was treated with breast conservation? You were treated with a mastectomy. I think the Z11 study that both of you referenced, when they had the completion dissection in that randomized arm, they didn't have a better survival or anything, but they did have over a 20% chance of finding additional positive lymph nodes. So what would be your thoughts if she had a mastectomy?
Well, it complicates things, right? I'm glad she had the lumpectomy because she is going to receive radiation therapy, which will cover part of the axilla. However, if she had a mastectomy, there would have to be a multidisciplinary discussion as to whether or not she does require post-mastectomy radiation therapy, whether she does require more surgery to the axilla. It kind of complicates things, and hopefully we'll get the answers to whether or not these lower risk patients do require more axillary surgery or post-mastectomy radiation therapy, because as we mentioned earlier, one of the main indications to treat with post-mastectomy radiation therapy is positive lymph nodes, but there's varying degrees of positive lymph nodes. In this particular patient, she has a 3 millimeter metastasis. Is that enough to justify comprehensively treating with radiation therapy now to the chest wall and the lymphatics? So answering your first question, yes, I'm glad she was treated with breast conservation. It makes my job a lot easier, and the tumor board's a lot less argumentative, if you will.
Thank you. And Dr. O'Regan, we talked about the Oncotype now on a couple of different occasions. This is a little bit different setting where there is a positive lymph node. Tell me, do you think additional molecular markers are helpful in systemic treatment decisions for positive lymph nodes, or how would you approach this?
Yeah, so I would send genomic profiling on this cancer for sure. So we have kind of two options, right? We have sending the Oncotype, which I'll talk about in a second, or we could also send MammaPrint, given that the MINDAX study that kind of investigated MammaPrint actually did include patients with N1 disease, so that would be very reasonable. I tend to lean towards doing Oncotype just because I think it's easier to kind of explain the chemo benefit to patients. That said, of course, we do not as yet have a randomized trial basically indicating the benefit of Oncotype in patients with N1 disease. That is pending and accrued. But there is quite a lot of retrospective data from a number of different databases, as well as from the SWOG study, the analysis that was done, showing that the Oncotype is useful in patients with node-positive disease. And the database have all shown that in patients that have low or even intermediate recurrence scores with N1 disease, that they do very well without chemotherapy. So I think either would be completely appropriate. I just tend to use Oncotype because it's easier to show to the patients. And provided her score came back, which I believe it probably would, in a lower risk range, I probably would not recommend chemotherapy to this patient. And I would just go straight to an aromatase inhibitor we talked about earlier.
Well, thank you very much.